CYP-450, Inducers, Inhibitors, and Key Subtypes. Board Review, Pharmacology Review. By Robin Trivette, Doctor of Nursing Practice, Masters of Nursing Education, Psychiatric Mental Health Nurse Practitioner. Hi everyone, I'm Dr. Robin Trivette, and today we're going to tackle one of the most tested pharmacology topics on board exams, the CYP-450 enzyme system. This is one of those areas that looks simple on paper but trips people up on test day because it's not just about memorizing a list of drugs. It's about understanding how drug metabolism changes when these enzymes are induced or inhibited. And that difference between speeding metabolism up or slowing it down can be the difference between a therapeutic dose and a toxic one. So, over the next approximately 20 minutes, I'll break this down step by step. We'll start with the basics, move into inducers and inhibitors, then finish with the most important subtypes, memory tricks, and a few board-style questions to lock it all in. If the lists never seem to stick, this is your moment to make it make sense. Here's the roadmap. What CYP-450 enzymes do, the drugs that induce or inhibit them, the key subtypes, mnemonics, and some high-yield exam tips with board-style questions. By the end, you'll understand not just what happens, but why. CYP-450. What they do. The CYP-450 system, short for cytochrome P450, is a family of enzymes in the liver that metabolize drugs. They perform mostly phase 1 metabolism, oxidation, reduction, hydrolysis, making drugs more polar for elimination. Inducers make these enzymes more active. Inhibitors slow them down. Remember, it's not the enzyme that's the inducer or inhibitor. It's the drug acting on the enzyme. Now let's look at the inducers. These are drugs that ramp up CYP-450 activity, speeding up metabolism. The mnemonic I use, and you've probably heard me say this before, is "Scrap G piece induces my rage." It's a silly phrase, but trust me, it sticks when you're under exam pressure. C stands for carbamazepine, R for rifampin, A for alcohol, specifically chronic use, P for phenytoin, G for griseofulvin, P again for phenobarbital, and S for sulfonylureas. Now, what do these actually do? Each of these drugs increases CYP-450 expression or activity, which means other medications get broken down more quickly. So if your patient is on warfarin and you add phenytoin, that warfarin level is going to drop. The patient's INR decreases, and suddenly the anticoagulation isn't working. This is a classic board question. It's like speeding up the conveyor belt in a factory. The drug gets processed and thrown out before it can do its job. Inducers, mechanism and clinical impact. On this slide, I want to walk you through what CYP-450 inducers actually do and why they matter clinically. Mechanistically, inducers increase CYP-450 expression and activity. That means the liver enzymes are working harder and faster than usual. As a result, any other drugs that depend on those enzymes for metabolism are broken down more quickly. Their plasma levels fall sooner and drop lower than they normally would. Clinically, that shows up as a subtherapeutic effect, in other words, treatment failure. The medication is still being taken, but the blood level is too low to do its job. When that happens, you may need to increase the dose of the affected drug or choose an alternative that doesn't rely on CYP-450 for metabolism. A classic trap you'll see on exams is when a patient is stable on warfarin or on oral contraceptives, and then someone starts phenytoin. Phenytoin induces CYP-450, so warfarin or the hormones in the birth control pill are cleared faster. The effect of those drugs drops off. The INR goes down with warfarin or the contraceptive fails and the patient becomes pregnant. So the overall pattern to remember from this slide is inducers speed up metabolism, lower drug levels, and cause treatment failure, especially with sensitive drugs like warfarin and oral contraceptives. CYP-450 inhibitors. Inhibitors do the opposite. They slow metabolism. The big ones? Valproate, ketoconazole, isoniazid, sulfonamides, chloramphenicol, amiodarone, macrolides, quinidine, grapefruit juice. These drugs increase levels of other medications and risk toxicity. On this slide, we're focusing on CYP450 inhibitors and what they do both mechanistically and clinically. Mechanistically, inhibitors decrease CYP activity. They either compete with other drugs for the enzyme or directly block its function. Because the enzyme is less active, the clearance of its substrates slows down. When that happens, those drugs are not being broken down at the usual rate, so their plasma levels increase and the patient has greater overall exposure to the medication. Clinically, that creates a risk of toxicity, a supratherapeutic effect, even if the patient is still taking what used to be a normal, safe dose. In these situations, you often need to lower the dose of the affected drug, or better yet, avoid the interacting pair altogether if there's a safer alternative. There are a few classic combinations that show up again and again on exams. One is warfarin with azole antifungals or macrolide antibiotics. Those inhibitors slow warfarin metabolism. Warfarin levels go up, the INR rises, and the patient is at risk for bleeding. Another is theophylline toxicity, when it's given with a strong inhibitor. Theophylline levels climb because it's not being cleared properly, and patients can develop serious side effects like arrhythmias or seizures. So the big idea from this slide is inhibitors slow clearance, increase drug levels, and raise the risk of toxicity, especially in drugs with a narrow therapeutic window, like warfarin and theophylline. Subtypes you must know. Fast mnemonics. We only need 5 on speed dial. CYP1A2. Acetaminophen. Acetaminophen. One word with 2 A's. 1A2. One word, 2 A's, 1A2. CYP2E1. Ethanol. You must be 21 to drink. 2E1. 21, 2E1. CYP2C9. Warfarin. Coumadin. Warfarin hits clotting factors. Think 2, 9, and C. 2C9. 2C9, warfarin. CYP2D6. Cardiovascular drugs. 2D echo. Cardio association, 2D6. CYP3A4. Most drugs. The workhorse. If nothing else fits, guess 3A4. Default, 3A4. Quick recap banner. 1A2 acetaminophen. 2E1 ethanol. 2C9 warfarin. 2D6 cardio. 3A4 most drugs. Inducers versus inhibitors snapshot table. This slide gives us a really clean snapshot of how CYP450 inducers and inhibitors behave and what they mean clinically. Let's start with the inducers row. When a drug is a CYP450 inducer, it increases metabolism. In other words, it makes the enzyme work faster. Because the drug is being broken down more quickly, the drug levels go down. Clinically, that leads to a subtherapeutic effect or treatment failure. The patient is taking the medication, but the blood level is too low for it to actually work. Now look at the inhibitors row. When a drug is a CYP450 inhibitor, it decreases metabolism. The enzyme is working more slowly. That means the body breaks down the drug more slowly and the drug levels go up. Clinically, that puts the patient at risk for toxicity and adverse effects because the same dose now results in a much higher concentration in the bloodstream. So in one line, inducers speed up metabolism, lower drug levels, and cause treatment failure. Inhibitors slow down metabolism, raise drug levels, and cause toxicity. If you can remember that pattern in this table, you'll be able to reason through most CYP450 questions on exams and in practice. Exam tips and traps. Let's finish this section with some exam tips and classic traps you'll see in board-style questions. First, if the question stem adds a CYP450 inducer, for example, rifampin or phenytoin, you should automatically expect the other drug in the scenario to become less effective. Inducers speed up metabolism, so the co-administered drug is cleared faster and its effect drops. Second, if the stem adds a CYP450 inhibitor, like ketoconazole or a macrolide antibiotic, then you should expect the other drug to become more toxic. Inhibitors slow metabolism, drug levels rise, and side effects or toxicity become more likely. Third, anytime you see warfarin in a question, pause and look carefully for a new inducer or inhibitor that was started. An inducer will lower the INR and increase clotting risk. An inhibitor will raise the INR and increase bleeding risk. The whole question often revolves around that Indian rupee change. Fourth, with oral contraceptives, the classic trap is the addition of an inducer. Inducers lower hormone levels, decrease the efficacy of the pill, and that's where you see those unplanned pregnancy stems, even when the patient is taking the medication correctly. And finally, for questions about specific CYP subtypes, if the answer choices include several enzymes and it's not clearly one of the big ones we've already talked about, like 1A2, 2E1, 2C9, or 2D6, the safest guess on board exams is usually CYP3A4, because it's the most common subtype and metabolizes the majority of drugs. So your exam pattern is: inducer means decreased effect of the other drug. Inhibitor means increased toxicity. Always scan warfarin and oral contraceptive questions for interactions. And when you're unsure on subtype, think CYP3A4. Section 2. Practice and Visual Review. All right, that wraps up the core concepts of CYP450. Now let's shift into Section 2, Practice and Visual Review. In this section, we're going to do 3 things. First, we'll walk through a set of board-style questions so you can see exactly how these CYP450 interactions show up on exams. Second, we'll use some visual mnemonics to lock in the inducers, inhibitors, and key CYP subtypes in a way that's easy to remember under test pressure. And third, we'll end with a few key takeaways, concise clinical pearls that tie everything together for both boards and real-world prescribing. So as we move into this section, don't just listen passively. Try to answer the questions in your head. Picture the enzyme activity changing and really test whether the patterns make sense to you. That's how this goes from memorization to mastery. Let's start with board-style question 1. A 32-year-old woman on warfarin is started on rifampin for tuberculosis. What will happen to her international normalized ratio? A. Increase. B. Decrease. C. Stay the same. D. Become erratic. The correct answer is B. Decrease. Here's the rationale. Rifampin is a classic CYP450 inducer. When you add rifampin, it speeds up the metabolism of warfarin in the liver. Faster metabolism means warfarin is cleared from the bloodstream more quickly, so the warfarin level drops. As warfarin levels go down, its anticoagulant effect is reduced, and the INR decreases. Clinically, that means the blood is clotting more easily, and the patient is at higher risk for thrombosis, things like DVT, PE, or stroke, unless the dose of warfarin is adjusted. Key takeaway. When an inducer like rifampin is added to warfarin, think increased metabolism, decreased INR, and loss of anticoagulant effect. Now let's look at board-style question 2. A 45-year-old man on simvastatin begins ketoconazole for a fungal infection. What is he at risk for? A. Myopathy. B. Rash. C. Hypotension. D. Bradycardia. The correct answer is A. Myopathy. Here's the rationale. Ketoconazole is a strong CYP450 inhibitor, specifically of CYP3A4, the same enzyme that helps metabolize simvastatin. When ketoconazole is added, it slows down the metabolism of simvastatin. That means simvastatin stays in the bloodstream longer and its plasma levels rise. Elevated statin levels increase the risk of muscle toxicity. This can present as myalgias, muscle pain, weakness, and in more severe cases, rhabdomyolysis, where muscle breakdown can lead to kidney damage. So the key idea is inhibitor plus statin, higher statin levels, myopathy risk. Key takeaway. When you see a statin combined with a strong inhibitor like ketoconazole or a macrolide, you should immediately think about muscle toxicity, not just a simple rash or blood pressure change. Next up, board-style question 3. Which CYP450 subtype metabolizes ethanol? A. CYP1A2. B. CYP2E1. C. CYP2C9. D. CYP2D6. The correct answer is B. CYP2E1. Here's the rationale. The easiest way to remember this is with the phrase, "You have to be 21 to drink ethanol." 21 corresponds to 2E1. CYP2E1 is the enzyme subtype that metabolizes ethanol in the liver. So when you see a question about alcohol metabolism or drug interactions involving ethanol, the key CYP enzyme they're pointing you toward is CYP2E1. Key takeaway. 21 to drink, 2E1 for ethanol. Board-style question 4. A patient taking oral contraceptives starts phenytoin. What is the most likely outcome? A. Toxicity. B. Treatment failure. C. No change. D. Severe side effects. The correct answer is B. Treatment failure. Rationale. Phenytoin is a strong CYP45-0 inducer. When phenytoin is added, it speeds up the metabolism of the hormones in the oral contraceptive, estrogen and progesterone. Because those hormones are broken down faster than normal, their blood levels drop, and the contraceptive becomes less effective. Clinically, that means the patient is at risk for unintended pregnancy, even if she's taking the pill correctly. So this is not a toxicity situation, it's a loss of effect. Key idea. CYP inducers like phenytoin lower drug levels and cause treatment failure, especially with sensitive drugs like oral contraceptives. Board-style question 5. A patient on valproate begins chloramphenicol therapy. What is the likely effect on valproate levels? A. Increased metabolism. B. Decreased metabolism. C. No effect. D. Converted to inactive metabolite. The correct answer is B. Decreased metabolism. Rationale. Chloramphenicol is a CYP450 inhibitor. When you introduce an inhibitor, it slows down the liver enzymes responsible for metabolizing other drugs. In this case, valproate is one of those drugs. Because its metabolism is now slower, valproate is cleared less efficiently, and its blood levels increase. As valproate levels rise, the patient becomes at higher risk for toxicity. For example, neurological side effects like tremor or sedation, and in more serious cases, hepatotoxicity. So the key idea here is an inhibitor like chloramphenicol causes decreased metabolism, which leads to increased valproate levels and greater toxicity risk. Remember, inducers speed drugs up and cause treatment failure. Inhibitors slow drugs down and cause toxicity. This slide is a quick overview of how drug metabolism changes under different CYP450 conditions. Under normal conditions, a drug enters the body, is processed by the CYP450 enzyme, converted into a metabolite, and then eliminated. So in the normal state, the body takes the drug, metabolizes it at an appropriate rate, and clears it in a balanced way. When CYP450 is induced, the enzyme activity is increased. The liver metabolizes the drug faster than usual, which causes the drug level in the blood to fall more quickly and to a lower level. Clinically, that leads to a subtherapeutic effect and treatment failure, because there isn't enough drug around to produce the desired response. When CYP450 is inhibited, the enzyme activity is decreased. The drug is cleared more slowly, so it stays in the bloodstream longer and the drug level rises. Clinically, that increases the risk of toxicity and dose-related adverse effects because the concentration of the drug becomes higher than intended. On this slide, I want to review the main mnemonics you can use to remember the CYP450 system. Let's start with the inducers. The mnemonic for the CYP450 inducers is "Crap GPS induces my rage." Each letter in CRAP GPS stands for one of the key inducing drugs. C stands for carbamazepine, R for rifampin, A for alcohol, specifically chronic use, P for phenytoin, G for griseofulvin, the second P for phenobarbital, and S for sulfonylureas. All of these are CYP450 inducers. They speed up metabolism of other drugs and can lead to subtherapeutic levels and treatment failure. Now let's move to the inhibitors. The phrase you can use here is, "Very kind, intelligent students can always make quick grades." Each word in that sentence represents one inhibitor. Very for valproate, kind for ketoconazole, intelligent for isoniazid, students for sulfonamides, can for chloramphenicol, always for amiodarone, make for macrolides, quick for quinidine, and grades for grapefruit juice. These are the major CYP450 inhibitors. They slow down metabolism, raise drug levels, and increase the risk of toxicity. Finally, let's quickly review the subtypes and what they're associated with. CYP1A2 goes with acetaminophen. You can remember this by thinking of the word acetaminophen as one word with two capital A's, which reminds you of 1A2. CYP2E1 is the enzyme that metabolizes ethanol. The way to remember that is, you must be 21 to drink alcohol, and 21 sounds like 2E1. CYP2C9 is associated with warfarin. Think of warfarin and the numbers and letter, 2, C, and 9. CYP2D6 is linked to cardiovascular drugs. The memory trick is 2D echo, like a two-dimensional echocardiogram used in cardiology. And CYP3A4 is the most common subtype. It metabolizes the majority of drugs in the body. So if you are unsure which enzyme is responsible and it's not clearly one of the others, CYP3A4 is usually the best guess. So in summary, use CRAP GPS induces my rage for the inducers. Very kind, intelligent students can always make quick grades for the inhibitors, and link each subtype to its key example drug or concept to make recall much easier on exams. Let's end with a few key takeaways, clinical pearls that tie this whole CYP450 discussion together. First, remember that CYP450 inducers, such as rifampin and phenytoin, increase the metabolism of other drugs. When metabolism speeds up, drug levels go down, and that often leads to treatment failure. Classic examples include a low INR in a patient on warfarin, or contraceptive failure in a patient on oral birth control. Second, CYP450 inhibitors, like ketoconazole and the macrolide antibiotics, decrease metabolism. That slows down clearance, causes drug levels to rise, and increases the risk of toxicity. For example, a patient on warfarin may develop bleeding when an inhibitor is added, or a patient on a statin may develop myopathy when its metabolism is blocked. Third, any time a patient's response to a medication changes unexpectedly, maybe the drug suddenly stops working, or they suddenly develop side effects, you should always consider whether a new medication affecting CYP450 was started. A new inducer or inhibitor is a very common cause of these changes. Fourth, recognize that warfarin and oral contraceptives are classic exam drugs that are heavily impacted by CYP induction and inhibition. On test questions, when you see either of those in the stem, immediately look for an interacting drug that might explain an INR change or a pregnancy. And fifth, when you are unsure of the specific CYP subtype, remember that CYP3A4 is the most common and is responsible for metabolizing the majority of drugs. On many exams, if the question does not clearly point to one of the more specific subtypes, CYP3A4 is often the safest choice. If you keep these 5 pearls in mind, inducers leading to treatment failure, inhibitors leading to toxicity, always checking for new interacting drugs, watching warfarin and oral contraceptives closely, and remembering CYP3A4 as the workhorse enzyme, you'll be in a strong position to handle 450 questions on boards and in clinical practice.